Welcome to Pinoy Medical Coder. Today, we'll discuss about clinical documentation integrity, CDI, COVID-19. Before we begin, please don't forget to like our Facebook page and like and subscribe to our YouTube channel. Goals: review coding instructions and CDI opportunities applicable to COVID-19 virus infection before and after April 1, 2020. Suggest management action plans applicable to COVID-19 infections. As of March 23, 2020, COVID current state in the United States, total cases of 33,404 and total deaths of 400. Clinical terminology. Virus name: SARS-CoV-2 or 2019 novel coronavirus, which differs from severe acute respiratory syndrome, SARS, coronavirus, SARS-CoV, that was prominent in 2002 to 2003. Middle East respiratory syndrome, MERS, coronavirus, MERS-CoV, that became prominent around 2014. Other coronaviruses that cause the common cold or other viral syndrome. Name of the disease: coronavirus disease 2019 or COVID-19. For all practical purposes, the term COVID equates to be infected with SARS-CoV-2 or 2019 novel coronavirus. Coding terminology as per Centers for Disease Control and Prevention, CDC. New ICD-10-CM code for the 2019 novel coronavirus, COVID-19, April 1, 2020, effective March 18, 2020. On March 11, 2020, the novel coronavirus disease, COVID-19, was declared a pandemic by the World Health Organization. On March 13, 2020, a national emergency was declared in the United States concerning the COVID-19 outbreak. Given these developments and the urgent need to capture the reporting of this condition in our nation's claims and surveillance data, the Centers for Disease Control, CDC, under the National Emergencies Act Section 201 and 301, is announcing a change in the effective date of new diagnosis code, U07.1, COVID-19, from October 1 to April 1, 2020. This off-cycle update is unprecedented and is an exception to the code set updating process under HIPAA. Elements of the CDC's announcement. At that time, the WHO classification team had noted that the virus name 2019 nCoV was temporary and is likely to change, to be independent of date and virus family, and for consistency with international virus taxonomy. Note: on February 11, 2020, the WHO announced the official name of the virus, COVID-19. A new International Classification of Diseases, 10th revision, ICD-10 Emergency Code, U07.1, 2019 nCoV acute respiratory disease has been established by WHO. The CDC is announcing a change in the effective date of new diagnosis code, U07.1, COVID-19, in ICD-10-CM from October 1 to April 1, 2020. This off-cycle update is unprecedented and is an exception to the code set updating process established under HIPAA and CHS amendments to the ICD-10-CM table. New code, U07.1, COVID-19. Add: use additional code to identify pneumonia or other manifestations. Add: excludes 1, coronavirus infection, unspecified B34.2. Add: coronavirus as the cause of diseases classified elsewhere B97.2. Add: pneumonia due to SARS-associated coronavirus, J12.81. Note that the excludes 1 note prefers the reporting of B34.2 and B97.2, or J12.81 when a coronavirus infection is present and COVID-19 is not explicitly confirmed by the physician. And CHS amendments to the ICD-10-CM index. ICD-10-CM Index List of Diseases and Injuries April 1, 2020 Addenda. Coronavirus 19, COVID-19, U07.1. Coronavirus, as cause of disease classified elsewhere B97.29. Add, Coronavirus 19, U07.1. Add, COVID-19, U07.1. SARS-associated B97.21. U07.1 applies to coronavirus infection. ICD-10-CM Index List of Diseases and Injuries April 1, 2020 Addenda. Infection, infected, infective, opportunistic, B99.9. Add, Coronavirus 2019, U07.1. Add, Coronavirus NEC, B34.2. As cause of disease classified elsewhere B97.29. Severe acute respiratory syndrome, SARS-associated, B97.21. Add, COVID-19, U07.1. Virus, viral, NOS, B34.9. ICD-10-CM Guidelines effective February 20, 2020. The guidelines have not been updated since announcement of the U07.1 implementation on April 1, 2020. Even so, there are principles that should be retained and others that should be amended in light of U07.1. What's to be retained? If the provider documents suspected, possible, or probable COVID-19, do not assign code B97.29 or a code for U07.1 after April 1, 2020. Assign a code explaining the reason for encounter such as fever or Z20.828. Exposure to COVID-19. For cases where there is a concern about a possible exposure to COVID-19, but this is ruled out after evaluation, it would be appropriate to assign the code Z03.818, encounter for observation for suspected exposure to other biological agents ruled out. For cases where there is an actual exposure to someone who is confirmed to have COVID-19, it would be appropriate to assign code Z20.828, contact with and suspected exposure to other viral communicable diseases. What's new? Authoritative but not official. Frequently asked questions regarding ICD-10-CM coding for COVID-19, revised March 24, 2020. The following questions and answers were jointly developed and approved by the American Hospital Association Central Office on ICD-10-CM/PCS and the American Health Information Management Association. U07.1 can be a principal diagnosis after April 1, 2020. Question: Is the new ICD-10-CM, U07.1, COVID-19 a secondary code? Answer: No, when COVID-19 meets the definition of principal or first listed diagnosis, code U07.1, COVID-19 should be sequenced first, and followed by the appropriate codes for the associated manifestations, except in the case of newborns and obstetric patients. Consistent with the use additional code instruction for U07.1. Prior to April 1, 2020, if a patient has confirmed COVID, the patient's manifestations are coded first followed by B97.29, other coronavirus as the cause of diseases classified elsewhere. MSDRG impact of U07.1. Assignment of the new ICD-10-CM diagnosis code U07.1, COVID-19 is as follows. Diagnosis code, U07.1. Description, COVID-19. CC, MCC. MDC and MSDRG. 04, 177, 178. 179. 15, 791, 793. 25, 974, 975, 976. All other MSDRG rules apply. If diagnosis code U07.1, COVID-19, is reported as a principal diagnosis, it will only exclude itself from acting as a MCC under the CC exclusion list. Principal diagnosis code, U07.1. Exclude secondary diagnosis, U07.1. Description, COVID-19. MSDRG's aspect of U07.1, major problems in newborns, MCC with OB. Prematurity. Major problems in DRG. Yes, 791. No, 792. Full-term neonate with major problems. DRG, 793. The appropriate 098.8x, X, code would be assigned followed by U07.1, U07.1 would be an MCC. MSDRG 974, 975, 976. MDC 25 Human immunodeficiency virus infection, HIV with major related condition. MCC, CC, DRG. Yes, NA, 974. No, yes, 975. No, 976. DRG 974 HIV with major related condition with MCC. DRG 975 HIV with major related condition with CC. DRG 976 HIV with major related condition without CC or MCC. Principal or secondary diagnosis of HIV infection. B20, human immunodeficiency virus, HIV, disease. And principal or secondary diagnosis of major related condition. A02.1, G04.81. A02.1, Salmonella sepsis. A02.20, localized Salmonella infection, unspecified. Requires that ICD-10-CM code B20 be either a principal diagnosis or secondary diagnosis. Z21, asymptomatic HIV does not qualify for this DRG. U07.1, will qualify as a major related condition, uncertain diagnosis rule. Question: does the supplement to the ICD-10-CM official guidelines for coding encounters related to the COVID-19 coronavirus outbreak apply to all patient encounter types, that is, inpatient and outpatient, specifically in relation to the coding of suspected, possible or probable COVID-19? Answer: yes, the supplement applies to all patient types. As stated in the supplement guidelines, if the provider documents suspected, possible or probable COVID-19, do not assign code B97.29. Assign a code explaining the reason for encounter, such as fever, or Z20.828, contact with and suspected exposure to other viral and communicable diseases. Coding only confirmed cases. Question: the supplement to the ICD-10-CM official guidelines for coding encounters related to the COVID-19 coronavirus outbreak refers to coding confirmed cases in a couple of instances, but it does not specify what confirmation means, similar to language and guidelines found for reporting HIV, Zika, and H1N1. Can you clarify whether the record needs to have a copy of the lab results or what lab tests are approved for confirmation? Answer: the intent of the guideline is to code only confirmed cases of COVID-19. It is not required that a copy of the confirmatory test be available in the record or documentation of the test result. The provider's diagnostic statement that the patient has the condition would suffice. Question: should presumptive positive COVID-19 test results be coded as Question: should presumptive positive COVID-19 test results be coded as confirmed? Answer: yes, presumptive positive COVID-19 test results should be coded as confirmed. A presumptive positive test result means an individual has tested positive for the virus at a local or state level, but it has not yet been confirmed by the Centers for Disease Control and Prevention, CDC. CDC confirmation of local and state tests for the COVID-19 virus is no longer required. Question: how should we handle cases related to COVID-19 when the test results aren't back yet? The supplementary guidance and facts are confusing since sometimes COVID-19 is not ruled out during the encounter, since the test results aren't back yet. Answer: due to the heightened need to capture accurate data on positive COVID-19 cases, we recommend that providers consider developing facility-specific coding guidelines to hold back coding of inpatient admissions and outpatient encounters until the test results for COVID-19 testing are available. This advice is limited to cases related to COVID-19. Conclusions: U07.1 starts on April 1, 2020. Coding of U07.1 requires explicit documentation that the virus causing COVID is confirmed. Summary: COVID coding changes are coming. Uncertain COVID cannot be coded. Recommended to hold the record for coding until after the studies have been received. The physician must interpret the findings and document it. Comorbidity and consequences must be defined, diagnosed, and documented. From James S. Kennedy, MD, CCS, CDIP. President of CDI MD, Physician Champions. Thank you for watching.